My topic is related to the sepsis-induced coagulopathy, which has become one of the most important but also most debated issues in sepsis management. So we know that the sepsis remained, and severe sepsis remained the leading cause in the intensive care units, and coagulopathy may significantly increase that risk. This dangerous complication affects approximately 20–25% of sepsis cases, with worsening organ failure and doubling mortality risk. However, unfortunately, despite decades of intensive research, we still lack of strongly recommended specific therapy. Thrombomodulin may offer a potential solution, however, its optimal use in the clinical field remained the subject of debate. So therefore, we conducted a systematic review and meta-analysis in order to better understand the clinical role of thrombomodulin, and found that thrombomodulin may help resolve the coagulopathy, however, its effect on mortality remains uncertain. And just before I present the details of our findings, let me introduce our team, research team. This project, the role of thrombomodulin in septic patient, is a part of the Translational Medicine PhD program at the Semmelweis University. Actually, this is the PhD topic of Timmy, who is a second-year PhD student in our team. And the mission of our team is to generate an evidence and then try to translate it into the clinical practice, aiming at personalized hemostasis management in clinically ill patients. So back to this coagulation disorders, which is a common complication of severe sepsis and strongly associated with worse outcome. The main driver is the overactivated coagulation due to an uncontrolled inflammation. And these changes lead to a widely microvascular thrombosis, hypoperfusion, and ultimately organ dysfunction. So in severe cases, the normal balance of hemostasis may be disrupted, lead to a hypocoagulant state, which is characterized by excess thrombin generation, impaired anticoagulant activity, and also suppressed fibrinolysis, which is known altogether sepsis-induced coagulopathy. Thrombomodulin. Thrombomodulin is an endothelial protein that protects this excessive coagulation by binding the thrombin itself and also by activating the protein C system, which is one of our most important natural anticoagulant system. And moreover, these activated protein C are able to improve this suppressed fibrinolysis. It is important to note that beyond regulating the hemostasis, thrombomodulin are able to stabilize the endothelium and reduce the inflammation. And in the clinician's point of view, the main rule of thrombomodulin is to protect the endothelium by decreasing the thrombin-induced damage and increasing the natural anticoagulation capacity of the body, and of course modulating the inflammation in order to preserve a vascular barrier integrity. So, given these properties of thrombomodulin, the recombinant thrombomodulin treatment appears a promising tool against sepsis-induced coagulopathy. However, the evidence remains so inconclusive, unfortunately, and therefore the international guidelines do not fully agree with its role in the clinical settings, and this uncertainty underscores the need for further study in order to better understand the role of thrombomodulin in septic patients. So we conducted this systematic review and meta-analysis following the PRISMA guideline, and our systematic search was performed across multiple databases and identified more than 2,400 articles. And after a careful screening, 27 studies were included in our analysis, 4 RCTs and 23 observational studies covering over 50,000 patients. And to answer our clinical question whether thrombomodulin improved the survival of patients with sepsis coagulopathy, we examined the impact of thrombomodulin on coagulopathy, bleeding, organ dysfunction, and also on mortality. So let's see our results. To assess the impact of thrombomodulin on coagulopathy, we compared the change of Japanese DIC score from the baseline to the day 7 between the two groups, the intervention groups, the patient treated with thrombomodulin, and the control groups. While this DIC score were similar at the baseline, This plot shows a 1-point reduction in the Japanese DIC score in patients treated with thrombomodulin as compared to the control group. However, it is important that this 1-point reduction is not only a statistically significant improvement, but also represents a clinically meaningful reduction because this 1-point reduction led to the resolution of coagulopathy in patients with sepsis. And this resolution was shown in this second plot here, this plot B. You can see that this plot represents or details the resolution of coagulopathy by the day 7. The resolution was defined as the Japanese DIC score decreased below 4. And as you can see on this plot, in a cohort of over 3,500 patients, the thrombomodulin treatment demonstrated a nearly 4-fold increase in the odds of coagulopathy resolution. So this finding highlights the significant positive effect of thrombomodulin on this clinical outcome. Risk of bleeding, this is our safety outcome. One of the primary concerns regarding this, or related to this thrombomodulin treatment, is the bleeding. However, our analysis found no increase in bleeding complication during the treatment and after the thrombomodulin treatment as well, which support the safe use of thrombomodulin in patients with septic coagulopathy. When we looked at the organ dysfunction, our analysis found no significant differences between the intervention and control groups in the overall organ function measured by this composite SOFA score. However, when we examine the ventilatory-free days as a special measure of lung function, the plot reveals a significant benefit with thrombomodulin. The patients in the intervention group requires 1.5 fewer days of mechanical ventilation as compared to the control group. But the question of whether the thrombomodulin has a primary impact on the lung function or a less consistent systematic effect on the overall organ function expressed by the SOFA score remains to be answered for further research. And finally, we examined the effect of thrombomodulin on mortality as well. Our analysis of the cohort of more than 8,000 patients found a significant reduction of the 28 days mortality in the patient treated with thrombomodulin. However, our findings was so inconsistent across the study types, which means that the randomized trials shows no significant effect, whereas the non-randomized trials found a significant survival benefit with the treatment. And basically, this is one of the main problems with the thrombomodulin, but with all this targeted intervention related to the coagulopathy. The observational studies shows a promising results. However, the RCTs are not able to confirm this. And of course, we all know that the non-randomized trials may overestimate the effect of the thrombomodulin due to its inherent biases. However, the RCTs, it is important to note that the RCTs, the randomized trials, also faced some significant limitations, such as the patient heterogeneity, the inconsistent definition of the coagulopathy, the varying concomitant therapies, and also the differing disease severity. And all of these limitations may have impacted their results. So therefore, our analysis concluded that thrombomodulin therapy remains a promising option in treating sepsis-associated coagulopathy without increasing the bleeding risk. However, the inconsistent findings of mortality stemming from this discrepancy between the results of RCTs and non-randomized trials leave its impact on mortality questionable. The future research, therefore, should focus should aim to refine and to standardize the diagnostic criteria of the coagulopathy and to stratify the patient according to the disease severity in order to improve the consistency in trials. And finally, let's see how can we translate our findings, our works, into our clinical practice. I think the most important message of our study is that the thrombomodulin therapy should reserve for those patients, for those sickest patients who has a progression in the organ dysfunction despite of this modern organ support therapy and with a clear evidence of coagulopathy. And it is very important. And it means that we need to, in our everyday clinical practice, we need to focus to the early recognition of the sepsis coagulopathy. And in order to achieve this, the regular monitoring is crucial. Not only to guide our treatment decisions, but to follow whether this condition, this coagulopathy, is progressing or resolving. So in short, I can say that the timely diagnosis together with the targeted therapy may be the case if we would like to improve the outcomes. And I had expected that I would run out the time, but I see just I have 3 more minutes. So I tried to summarize our clinical practice as well, what we can do in our department. So I try to perform this visual summary. And so we know that if we have a septic patient with coagulopathy, these coagulation disorders ranging from mild or subclinical coagulopathy to the fulminant intravascular coagulopathy to the fulminant DIC. However, the group we are really need to identify those patients who are at the stage of the thrombotic DIC, of the thrombotic coagulopathy. This patient is characterized by the progressive organ dysfunction and clear signs of hypercoagulation with a fibrinolytic resistance or shutdown. And it's very important to identify this patient because this is the therapeutic window where this targeted intervention may be the most effective. However, of course, this patient already has the consumption of some factors, but which is very important without the clear and strong signs of factor depletion. And if we found this patient in this very stage, then the bleeding is usually not a concern. The other thing is that the shift from the hypocoagulative state to a hypocoagulative state is very dynamic. Therefore, a sequential measurement is crucial. What we measure the conventional parameters. Why? Because we would like to calculate the 6 score. If this CIC score is positive, then we check the blood, check the inflammation in signs of the blood with viscoelastic test. This is the hypercoagulation and the fibrinolytic shutdown. If it's positive again, then we measure the level of the antithrombin levels, which is one of the natural anticoagulant. And if it is low, then maybe we give patient a targeted intervention. How? That's the question. How? Because the international guidelines, it's so inclusive. That's why we follow the recommendation of the Japanese guidelines, which is brand new. It just came out a few months ago. And they still suggest the anticoagulant therapy with antithrombin or thrombomodulin. Moreover, they increase the grade, the level of the recommendation from 2C to 2B. And how? This is the practical details. In our practice, we use antithrombin 3 because, unfortunately, here in Europe, as far as I know, the thrombomodulin hasn't got any license. So that's why we use the antithrombin 3, and we try to use these recommendations. Thank you very much for your attention.